All right, so welcome along to this month's Coaching Corner. My name's Suean. I'll be talking to you tonight about fetal wellbeing assessment. So I want to look at the different aspects of the fetal wellbeing assessment examination. Now, I'm not diving too deep into like an obstetric version or a tertiary level scan here. I'm just kind of keeping it up the top with some simple things that we can look at to assess the fetal well-being. I'm going to keep it just umbilical artery Doppler because until you master that and until you can do an umbilical artery Doppler very easily and quickly, you shouldn't be messing around doing middle cerebral artery Dopplers. So you have to have really good Doppler skills and ability to navigate your way around the machine so that you're not exposing the baby and to potential thermal effects while we're trying to get the middle cerebral artery Doppler, which is pertinent given our conversation just before. And last but not least, we're going to have a really brief look. I'll just mention the whole biophysical profile thing, but it is falling out of favour these days. So the goal of the third trimester ultrasound assessment is typically to establish growth and health, to determine if there are any fetal movements. We look at the placental appearance and position, and we assess the fluid. We then move on to assess blood flow as an indicator of a normal functioning placenta. And the way we can do that is by looking at the umbilical artery Doppler and the middle cerebral artery Doppler. So we'll get stuck in. The first one is measuring the heartbeat. And this one's the most simple, right? And it's the most satisfying when you have a patient there and you can show them the heartbeat. You can have a quick listen if you like using the Doppler at this stage, or, just do an M mode trace and, show the mum that, yes, baby's heart's beating. And then they all take a big deep breath and then we can get on with the business of doing the fetal wellbeing assessment. But for the fetal heart rate, it doesn't matter so much about what the numbers are. It's just about documenting the rhythm, and the M mode trace is a really nice way to document motion over time, and so we can see that there is fetal heart movement, and it demonstrates along the y-axis, the x-axis here, with that motion over time. The next thing that we can assess very quickly and easily, and it doesn't require too much fine detailed probe movements, is quite easy to do, and that's to assess the amniotic fluid index. So the amniotic fluid index is a semi-quantitative assessment of the amniotic fluid volume in the uterus. If there's too much or too little amniotic fluid, it can be associated with increased pregnancy risks. The AFI will vary with gestation, and it tends to decrease in the third trimester, and especially after 40 weeks gestation. And there are three ways that you can do this. You can either look at it subjectively, you can do a maximum vertical pull, or you can do the amniotic fluid index. So the scan technique here, firstly, if we look at the subjective assessment, I have to say, once you've been scanning obstetrics for a long time and you've done a lot of these, and I'm talking hundreds of fetal wellbeing assessment exams, you get a good feel for whether the fluid looks normal or not just by looking around the tummy, without having to do all the additions and measurements and stuff. And what I'm looking to see, if we've got a good view of the baby's face, is can I see any fluid around the baby's face? And as we slide down to the baby's waist, can I see a puddle of fluid and see that the baby is surrounded by fluid with a good amount of space between it and the edge of the uterus? What we're looking to see is that there is enough fluid for the fetus to move freely and to delineate the anatomical structures. So if you're struggling to see anatomical structures, it's probably because there's not much fluid. And you can take a clinical history from your patient. But on those patients of a normal body habitus, obviously when you have larger ladies, they can often be hard to assess regardless of what we're doing. But the amniotic fluid, the sound interacts well with the fluid and passes through the fluid well. So if there's enough amniotic fluid around the baby, there is enough of a window to be able to see the detail of the fetal anatomy. So if there's not enough fluid around baby and we're just going through isoechoic layers of different tissues, then it's hard to see that fetal detail. So that's one of the first things. And I find myself kind of looking at that and going, and this is only with lots of experience, looking and going, I think it looks good, and then doing the numbers and the addition of the different pockets or the maximum vertical pool to back up my subjective assessment. But of course, that doesn't work when you're first learning ultrasound. You can't just all of a sudden know how much is enough. You have to have seen hundreds of them. So we all like a number, and it's better to have a number that we can evaluate. Yes, well, it's too much or too little, and there's a line drawn in the sand about, well, how much is too little and how much is too much. And so the first way of the numerical method to calculate how much fluid there is a maximum vertical pool, or you might have heard of it as the deepest vertical pocket. What you do here is you put the probe on. It doesn't matter if it's in longitudinal or transverse section, because we're going to be measuring the depth. And regardless of which way you are holding your probe, in longitudinal or transverse, the depth is still exactly the same. So you put your probe on the abdomen and you need to scan around the whole belly, looking at all the different quadrants of the belly, and you're just looking for the biggest pocket of fluid. And wherever you can see that deepest pocket of fluid that has no limbs in it and no cord in it, that's where you take a vertical measurement. Whereas the amniotic fluid index is essentially exactly the same thing, but we're doing a deepest vertical pocket or maximum vertical pool in each quadrant. Now, it doesn't matter which quadrant you number, which quadrant here. I usually start quadrant 1, bottom right of the maternal abdomen. It really doesn't matter. You just need to get into each quadrant and take the deepest vertical pool and find a pocket in each quadrant that doesn't have any limbs in it and doesn't have any cord in it. And then you add them up to get that final number. Now, the trickier thing here, and the very important thing, is that you need to make sure that you stay perpendicular to the bed. You don't want to have too much probe angle on the transducer, because then you can artificially make these pockets bigger than they are. And so it's really important to make sure that when you're holding the probe on the abdomen, that you are keeping your probe upright and vertical. We want to keep it perpendicular to the bed, and that we're not tipping our probe one way or the other, or even forwards and backwards, so that we're artificially enhancing how big that pocket is. The other thing to think about here is how much pressure you're putting on. So, and particularly in your larger ladies, sometimes you have to push quite firmly to get a nice picture. And so it's a real balance, particularly on your larger ladies. There's a real balance between how firmly you push to get a picture and whether that much pressure is actually dispersing the fluid. So you need to be careful to not push so hard as that you disperse the fluid. So when we take the vertical measurement, or the deepest vertical pocket, whether it be that one single measurement over the whole tummy, or whether it be in each quadrant as in the amniotic fluid index, we want to measure that largest pocket that contains no umbilical cord or any fetal parts. And we also need to be careful that we're going to the edge of the uterus. Now, in that near field of the ultrasound, sometimes you can get some near field reverberation and some artifactual echoes that sort of write themselves in this sort of superficial region. So you need to adjust your gain settings here to make sure we've got black fluid and grey or hypoechoic edges of the uterus. And the measurement goes from the edge of the uterus to the deepest part at the edge of the uterus. Again, be careful to not apply too much pressure that you're dispersing the fluid. A lot of the more advanced machines will have a split screen option on them, and even some of the point of care systems now have a split screen option on them. Now, I love them. When you're doing a full obstetric scan, I love them. It's one picture, and I think that probably stems from the old days when we had to print out and physically print by chemicals and all the rest of it, sheets of film, whereas now that space is not so important, so it doesn't matter so much. But the reason I like the split screen is that I get those 4 images and a representation of how much fluid is around baby all on one image. It doesn't matter, in effect, whether you do it on 4 separate images, but if you pop it all on the one image like that, you can see it all all at the same time, and it tells a single story without having to flick through lots of pictures. The tricky thing with this, though, is that you have to get used to how your machine works. And the most frustrating thing in getting into the groove of using your machine is getting this tool to function properly so that you don't take a measurement and then lose it when you move on to the next quadrant. So there's a little bit of finessing the button pushing here so that you can do this well without losing information as you go. So check and see if your machine has this function and practice it without a patient so you get the order of the button pushing right, and then it'll flow more smoothly, because there's no doubt once the patient's there, there's a bit of extra pressure on it, and I don't know, I found myself many times on a machine kind of muttering under my breath and getting very frustrated because I couldn't get this to work properly. But it's just getting into the groove of what the order of the button pushing here is, and then it demonstrates that whole sort of amniotic fluid index on a single picture. And for each measurement that you make, you need to make sure that those measurements then record to the reports page on the machine so that it comes up at the end when you print your reports page out. So let's have a look at what does too much, too little. What are the sonographic signatures of the amniotic fluid index? So when we look at the maximum vertical pool, we are just measuring the deepest pocket. So you might find lots of little pockets, but you need to find the single deepest pocket, and you just measure that one pocket vertically. Your probe is vertical and perpendicular to the bed, and the measurement that you take is a vertical measurement. If the maximum vertical pool is less than 2 centimeters, it's oligohydramnios. If it's 2 to 3 centimeters, it's reduced. 3 to 8 centimeters is in the normal range, and more than 8 centimeters in any single spot is considered polyhydramnios. When we look at the amniotic fluid index, we have fluid distributed around the tummy, and sometimes you might find one quadrant has nothing and there is no fluid there. So don't be worried about that. But what we're doing here is adding up each measurement in each quadrant until we come up with the sum. And we're looking for the normal amount of fluid to be between 10 and 20 centimeters. Now, as the pregnancy advances or the gestation advances, the amount of room and the amount of fluid that you'll be able to see and calculate will naturally appear to decline. I think the same amount of fluid's there because it doesn't escape, but it's just that baby takes up more space now and you can't see as much fluid. So, at 32 weeks, you might get very different numbers to 38 weeks. If the 4 measurements summed is less than 5 centimeters altogether, then it's considered oligohydramnios. And if it's more than 25 centimeters, it's considered polyhydramnios. Now, the thing about this is that you need to match those findings with the clinical picture. So if your patient has come in and there's a clinical history of query spontaneous rupture of membranes, well, then that makes sense. But if there's been no history of, that they've lost water or that their waters have broke or anything like that, finding oligo or polyhydramnios is extremely important because it can indicate that there are other abnormalities going on. And sometimes this can be the first sort of sign of it. And I had a case one time. It was a lovely Indian couple, and they were super anxious and super eager husband who, just wanted to know what sex the baby was. Really agitated mum because she was so uncomfortable. She was 32 weeks. Her belly was just enormous and her skin was so itchy and she was so uncomfortable. And she couldn't lie still on the bed for me. And it was in the middle of a busy day. And I'm like, oh, gosh, can you? Because every time she moves, if you lie them on the side, all the fluid will pool on the gravity-dependent side. And so she was particularly uncomfortable lying on her back and just was constantly fidgeting. Anyway, I saw that there was heaps and heaps of fluid. And our protocol at the time was that you did the fluid, you did the biometric measurements, you looked at the 4-chambered heart, I think, and the umbilical and middle cerebral artery Dopplers, and that was a complete scan. But I'd had a case not long out of student where I'd scanned a spina bifida child who that diagnosis had been missed during her pregnancy scan, so I was always paranoid about it. Part of my 3rd trimester scan was always just to check the skin line and check that the spine was all intact, because everything's much easier to see. Anyway, I scanned the spine on this baby, and this was the first time that it was discovered she had an 8-centimeter sacrococcygeal teratoma. And one of the things that you can get with that is polyhydramnios. And so when you find oligohydramnios or polyhydramnios, it could be indicative of other things that are going wrong that may not have been so obvious early on in the pregnancy. So for this lady, it meant that they could change the mode of delivery. Baby was delivered by cesarean section. There was no damage done to the spinal canal as the baby was born. The sacrococcygeal teratoma was resected, and the child had full neurological function and presumably grew up to be a normal, healthy kid. But without having found that at that stage, who knows? The vaginal delivery might have caused damage to the spinal canal and to cause problems with the birth. Oligohydramnios can be associated with a lack of swallowing or other congenital problems. So when you see this, if there's no obvious reason why, for example, they haven't had rupture of membranes or whatever, a picture of oligohydramnios or polyhydramnios is an alarm bell saying, look further, or if you're in a point of care setting, you need to refer them for further investigation. So here are some examples of oligohydramnios. And if you suspect oligohydramnios, it's probably easier just to get a single vertical pocket if you can find one. But as you can see here on these images, there is no fluid around the abdomen here, or around the abdomen, or around the head. And so now we don't have any fluid delineating the fetal structures, and therefore everything's a little bit harder to see. And again, over here, we don't have a good, and these are quite early gestations really, but we don't have good delineation of these, of the fetal abdomen there and around the head. And so, it then starts to ring those bells. Is this because they've had premature rupture of membranes? Is there any signs of uteroplacental insufficiency? Are there any genitourinary malformations? Or later on in pregnancy, are they post dates and this starting to cause a problem? So things like renal agenesis or non-functioning kidneys or obstructive uropathies or some sort of viral infection can also cause polyhydramnios as well. So again, if you find either one of these, it's just an alarm bell ringing that something else is going on. Here's a case of polyhydramnios, and you can see here with that split screen view, it doesn't matter where you go on this abdomen, there is massive amounts of fluid, and you can see that very clearly. So we're taking that single vertical pocket measurement. So, according to the cutoff date, the cutoff limits that we had, a single vertical pocket of more than 8 centimeters here says polyhydramnios. When we've calculated the AFI and we have the 4 measurements, there's fluid absolutely everywhere, and anything over 25 centimeters is abnormal. Most of the time it's idiopathic, 60 to 65% of the time it's idiopathic, but it can be due to maternal causes such as diabetes or massive congestive heart failure, or it can be due to problems with the bub. So central nervous system abnormalities, like I was just talking about, like the neural tube defect, gastrointestinal obstructions, esophageal or duodenal atresia, or umbilical gastroschisis. Could be a cervicothoracic abnormality, cardiovascular abnormality. In twin pregnancy, we're looking for twin-to-twin transfusion syndrome. So, if you see one twin and their sac is really overfull and the other one's a bit squashed up, then that again is cause for referring on and getting further investigations. So let's do some troubleshooting. And what are the things that the common mistakes when you're doing the AFI? The easiest way to underestimate the AFI is to have incorrect gain settings. And so you can see how here we've got some near field reverberation. And it could be easy to put our measurement down a little bit and sort of leave ourselves a couple of centimeters short. So on this image, you can see there's quite a lot of bright white right around the edge, and it's too bright white and it's too harsh on the eye. So if we wind the gain down, that will help to overcome this. The other thing you can do is measure too laterally and not measure the vertical pocket, the deepest pocket. You can be pushing too hard and displace the fluid. And it's very easy in your larger ladies to underestimate the AFI. It's a combination of pushing hard enough to get a clear image and displacing the fluid, but also because everything just looks a little bit fuzzy and the image quality is not great, it's harder to define the edges of the uterus. You can overestimate the AFI. Now, the common way here is to measure a pocket of fluid that has got either fetal body parts in it or that has got the cord in it. So we want to measure a pocket that has no parts and no cord in it. So you can overestimate if you incorrectly measure here. The other thing you can see on this image, the angle of the probe here. And so that means we cut through an oblique section of the uterus. And so that can then artificially elongate that pocket. So we need to keep our probe perpendicular to the bed and very vertical on the patient to measure the deepest vertical pocket. And sometimes you can just measure it crooked. Now we want to go straight up and down, we're measuring the depth. So if you measure crooked like this, a centimetre in each pocket could make all the difference. One of the pitfalls of doing an amniotic fluid assessment is it's hard to see sometimes where the loops of cord are. So I always just recommend just pop your colour Doppler on really briefly to make sure that you're measuring a pocket that hasn't got the cord in it. Another pitfall that we can see is you can incorrectly measure the bladder here. Hang on, I was just getting some of those questions up. I'll come back to those questions at the end. This here is the maternal bladder, so you don't want to mistake that for a pocket of fluid. And on the picture on the right here, we've got these big cystic structures within the fetus. And in this case, it's probably due to posterior urethral valves in the fetus. But we've got the fetal bladder here, and these are the fetal kidneys. So we just need to make sure free fluid or amniotic fluid should conform around and fit into all those nooks and crevices. Whereas this is clearly within a structure and it's pushing things away and it's very round and contained, so it can't be free fluid. So just because it's black and it's fluid doesn't mean that that's what we measure for the amniotic fluid index. We need to make sure we're measuring the amniotic fluid. So that's Doppler. I'm just going to, I noticed there were a few questions here. I'm just going to pause for a second and we might see if we can answer some of those questions now before we move on to Doppler. So do the numbers range of abnormal and abnormal change according to BMI? Not that I know of. I'm happy to be corrected on that, but we've always just used the fixed numbers. Is there plankton in the amniotic fluid or is it the gain? Sometimes you can get vernix, the white stuff that covers the baby. Sometimes you can get little floaty bits that you can see if you're overgained particularly. You can see those little floaty bits within the amniotic fluid. The thing here is you need to wind up the gain so that you can figure out where the edge of the uterus is, but you then wind down the gain until the fluid is black. If those echoes disappear, then it's probably artifact. If those echoes remain, it's probably because it's the edge of the uterus. So it is just about playing with that gain a little bit. But certainly when the gain is turned up too high, it makes that floating sort of vernix stuff, and they do look like plankton, as you said, it makes it seem much more obvious. How do we assess AFI in multiple gestations? I have to say most of the time I would subjectively do this, because if you're talking about, I'm not sure if there are actual numbers for what should be in each sac, but trying to figure out where the inter-twin membrane is in second and third trimester can be very, very difficult. So you can either kind of look at the 4 pockets or find the deepest vertical pool and look on the left side of the uterus and the right side, is it vaguely in the 2 sacs? But most of the time I'm subjectively assessing this. And when it's not right, it's usually obviously not right. I've never seen something where I've been, oh, is it or isn't it? By the time we've got twin-to-twin transfusion and we've got an imbalance in those amniotic sacs, by the time that presents that we're investigating, it's usually quite obvious in my experience, and one side's way too much and one side's way too little. But I'll have to look it up and see whether there's any specific guidelines around that. I've never done specific, each side of the uterus or anything. It's more a subjective assessment. I think that's got all those questions. Did anyone else have any questions before we move on?
It's not a question, it's an answer. We do, for twins, we do the deepest pocket in each sac.
Yep.
So the deepest vertical pocket in each fetal sac.
And with that, if I was going to do a measurement, that's what I probably would have done. With that, you're kind of going, okay, one baby is positioned superior, inferior. So you do the top half of the uterus and the bottom half, or it's one baby's positioned left and right. So you make sure you're left of midline, right of midline, because trying to figure out where the intertwin membrane is can be quite difficult on these. Thanks, Noki.
No.
Where are we at again? Hang on, share the screen. So we'll move on to Doppler. And as I said, I'm just going to cover off on umbilical artery Doppler. I think middle cerebral artery is an advanced skill, and you need to have, as I mentioned right at the beginning, you need to have good Doppler skills before you venture near this one. So first of all, I just want to look at some of the principles so that you can kind of understand, how is it if we measure the umbilical artery, why does that give us information about the placental bed? Well, I'm sure everyone's had this situation happen where you are out hosing the garden or, cleaning off the deck, whatever it is that you're doing with the hose, and all of a sudden you lose pressure at the end and you just know that that bloody hose has just kinked somewhere up the line. It always happens. Even if it's a non-kink hose, it will still kink up somehow. We instinctively understand when we're looking at the hose where the water's coming out, we instinctively understand by looking at the flow at the tap, at the hose end, that something upstream has happened that has caused it to be so that we aren't getting enough water coming out. Now, either there is a kink in the hose and, baby's tied the cord around in knots and they're leaning on it or something like that, or someone's turned the tap off on us. So if we imagine if one end represents the placenta and the other end represents the baby, if we take a measurement somewhere in between here, we can infer what is happening upstream. If someone turns the hose off while we're hosing, you know that because of what happens on the end. So this is kind of like there's not enough blood flow coming from the source or the placenta. So if the placenta isn't functioning properly, there's either going to be an increased resistance to flow in the placental vessels, and we are going to see that effect on the baby. So if there's not enough blood getting to baby, then we start to see consequences of that. And I always liken it to baby is like a parasite. It will thrive at our expense, and it will preserve what it needs to survive. And so when we look at the umbilical artery Doppler, if we were to measure the resistance to flow, it should be low, because the baby, as a parasite, it definitely needs forward blood flow in order to grow and thrive. If there is a restriction to blood flow, it will stop thriving. And so as baby needs continuous forward blood flow through all stages of that cardiac cycle, so in systole and in diastole, it needs blood flow all the time to keep growing healthily. The umbilical artery is a big vessel, so we can look at the amount of flow in the diastolic portion of the trace to see, well, is it still getting flow in the diastolic portion? Now, if we look at middle cerebral artery, for example, by the time blood gets through the cord and through the baby and up to the smaller vessels in the head and in the brain, there's a lot more pressure and a lot more resistance to flow because those vessels are getting smaller and smaller. So the Doppler traces in the head should be high resistance flow. And so we have the umbilical artery, low resistance flow, forward blood. The middle cerebral artery, high resistance flow because everything's got smaller and smaller and smaller. When they flip around, when we have high resistance flow in the umbilical artery bed, that infers poor placentation and some sort of restriction to the umbilical flow. The baby then fights to preserve the vital organs. And so one of the vital organs is the brain. And so the brain then becomes really hungry for blood. And so then the middle cerebral artery trace will be low resistance. So when I look at the umbilical artery trace, you can see here in diastole, there is a lot of flow. And here, even in systole, I should say, in systole, there is a lot of flow. And here in diastole, we still have forward flow above the line. When we look at the middle cerebral artery, in systole, we have strong flow, but in diastole, there is far less flow. So this is a high resistance trace in the middle cerebral artery and a low resistance trace in the umbilical artery. Now, we use some common indices, and I've worked in a few different places that have used different ones, but the current sort of standard is to use the pulsatility index. As you can see, they're all variations on the same theme. We use these ratios so that we have, and the pulsatility index in particular is the one that's commonly used around the world and the preferred index, especially for research purposes, because the pulsatility index will show a linear correlation with vascular resistance, and it uses time averaged velocity. So in that ratio, it includes temporal information over the whole cardiac cycle. And the pulsatility index is much more reproducible than other indices. The SD ratio and the resistive index show a parabolic relationship with increasing vascular resistance. And so it's easier to sort of follow up and measure with the pulsatility index. And handy that we're all talking the same language and measuring the same thing. So when you see this, just make sure that you are using the same indices that have been reported and to compare against what's happened before. So in the normal fetus, the resistance to flow, or the impedance, decreases in the umbilical artery because of increased numbers of stem villi as the placenta matures. All of these measurements serve as a surrogate marker for the well-being of the fetus. And by assessing the impedance within the fetal placental circulation, it's an indirect measurement of that resistance to flow in the placental vasculature. So you can see here with the PI, it's a much more linear relationship. And you can see as the gestation increases and the size of the baby increases, it needs more blood flow, the resistance to flow decreases, and that's normal. And you can see on these charts, you want your measurement to fit between the top and the bottom line here. So we're looking for anything between the 5th and the 95th centile. They also use, when they're doing middle cerebral arteries in more tertiary settings, they use the middle cerebral artery ratio with the umbilical artery. And an abnormal cerebroplacental ratio reflects redistribution of the cardiac output to cerebral circulation. If the value is more than 1, it's normal. If the value is less than 1, it's abnormal. So when you're taking a measurement of both, then it can give you a good indication that as a predictor of adverse outcomes for the baby. So an abnormal cerebroplacental ratio might occur when they've got a low normal range middle cerebral artery, but an upper normal range umbilical artery, if you've got abnormally low middle cerebral and normal umbilical artery, or an abnormally low middle cerebral and a really high umbilical artery. So this ratio kind of takes into account both of those measurements to give you a single figure that you can then kind of go, well, this baby's more likely to be in trouble than others. So it can be quite helpful. So when we look at the scan technique for the Doppler artery, there's always 3 steps. You need to optimize the B mode image first and make that as good as it can possibly be. Then optimize your color and then optimize the Doppler settings or the pulse wave Doppler settings. So when we optimize the B mode, first of all, when you're scanning, you look at which way baby's positioned, and you can tell by which way it's positioned which side is more likely to have cord on it. So you can go hunting for the cord on that side. So identify the cord. You then need to adjust the depth so that we make that cord as big as possible, and then you can zoom. So don't apply the zoom straight up. You need to adjust the depth and the gain and make the best possible B mode image before you zoom. And what we're trying to achieve is that the umbilical artery and the umbilical vein in the cord there are as big as possible on the screen to make the positioning of our spectral trace and our Doppler gate to make that positioning much more easy. When we look at the color, you activate the color flow and you want to position and the color box so that you have got it over the umbilical artery Doppler, and we want to keep the color box as narrow as possible. The wider the box is, the more information you're asking the computer to process, so the frame rate slows down and we lose that temporal resolution. And the same thing happens if we have the color box set too deep. The sound has to go deeper into the patient and then reflect back, so it takes longer for it to make that transit. And so the thing that trades off here is the temporal resolution. So we need to position the color box over the cord and then make it as narrow and shallow as we can so that we optimize the temporal resolution of the system. Then we look at the color scale so that we haven't got too much aliasing, and you may need to adjust the color gain here. We're just looking to find that there's a little bit of aliasing in the artery. The blood should be flowing faster in the artery, and that helps us to determine which one's the artery and the vein. When you have too much aliasing, all that's happening is that your sampling rate is not fast enough to be able to accurately represent the information. And so the machine starts to borrow colours from the other side of the Doppler spectrum to demonstrate the flow. And so you can see here, this one's the artery and this one's going a bit slower, and it's the vein. And the aliasing is the multiple colours here. Last but not least, we then apply the pulse wave Doppler. So you select the pulse wave and activate it. You need to position the cursor, activate the trace, and then optimize your trace. Now we're looking to achieve 5 even pulses to measure the PI values. Sometimes your machine will automatically do that for you. And so if you've got a poor trace, the machine just gets very confused. So you need to have optimized everything along the way to make sure that the quality of your Doppler trace is as good as it possibly can be, so that the machine knows how to identify those if it's on auto calculate, or so that you can clearly delineate where the peak systole and peak and diastole are. So then you go into your calculations package and plug in the numbers. And again, that's the process of figuring out how your machine works. Each machine has got slightly different quirks. So when we look at the waveform, we can, even without any measurements, you can tell a lot about what's going on and the health of this baby just by eyeballing it. Now, as you can see here, a normal trace should have a nice sawtooth sort of pattern. We want to see good systolic flow and a lot of positive diastolic flow, because the baby needs forward flow in all parts of the cycle. So when we take that measurement, we take the peak systolic flow here and the end diastolic and plug that into the machine. The pulsatility index requires that you trace the line from peak systolic to end diastolic to map out the time averaged velocity. Now, early in pregnancy, you have a very little fetus. The vessels are all very small, so they are high resistance. As the baby gets bigger, it requires more blood flow, so the resistance to flow decreases. So you can see in first trimester, it's very, very high resistance with no diastolic flow. In second trimester, high peak systole, and there is some diastolic flow in diastole, but it's not very much. And then in third trimester, we need to see more flow here in diastole. And again, this is a normal pattern. So we see that resistance to flow decreasing with advancing gestational age. So the normal Doppler has that classic sawtooth pattern. We're looking to get 5 peaks, and we measure the peak systole, end diastole, and you can see the trace going from peak systole to end diastole here. Once you have that measurement, you can, there are calculators on perinatology and fetalmedicine.org where you can just plug in the patient's gestation and it'll give you the 5th and 95th percentile for their gestation. So you can plug it into these pages quite easily to determine if it's normal or abnormal. Typically in the imaging department, we've got graphs and worksheets that you can map it out on and you can track it as time goes by. When we look at the umbilical artery, it's a linear relationship here, and we need to see the umbilical artery in between the 5th and the 95th percentile. Now, how do you know that it's abnormal? The first thing you see is kind of like a 3-step phase. It progressively gets worse, and what we're trying to do is catch this at the ideal time to get baby out safely. So the first phase of the Dopplers going off, if you like, is that it has high resistance flow. And so we see not much diastolic flow. There is still some, but not much. The second phase is that there's absent diastolic flow. And the third and most severe form of this is that there is reversed diastolic flow. So when we look at a high resistance waveform, you can see that before we had the end diastole sort of sitting at about 50% of the way up, whereas now it's kind of at 25% of the height here. So just looking at that trace, it's looking like a higher resistance trace. Then it progresses to absent flow during diastole, and then we get reversed flow in diastole. Now, in my experience, if I've ever found this, the baby has been out that afternoon, and everyone gets very, very worried, and the baby is out within hours when it's like this. Throughout all that, you just need to keep in mind we want to keep the dose of Doppler and all the rest of it as low as reasonably achievable. And that's why I was saying to you, until you know how to do an umbilical artery trace well, don't even bother about the middle cerebral artery. You need to be able to navigate those Doppler controls and be really fluid and comfortable with them before you start putting extra extra heat into the fetal brain structures. So if we look at the troubleshooting, it's very easy to take a Doppler of the wrong vessel, and so you'll get a venous trace rather than the pulsatile artery. So the artery goes psh, 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 and the vein will sound like it goes psh, and you'll see it just with a steady diastole. We want to optimize the trace here, so make sure we've positioned this as well as we can and just make sure we've got our gain settings right in the spectral trace. If we've not optimized our B mode images, our target's all that much smaller. We're chasing smaller things. It's harder to keep focus on it. It's harder to get the measurements. So in this image, I'd like to adjust my focus up to the right level and put it at the level of the umbilical artery. I'd reduce my depth to about this level, which would then make everything appear bigger. And then I could then also zoom on the vessel itself. The other thing, and we mentioned this briefly before, the size of the box makes a big difference here to the temporal resolution. So the width of your box means how much information the computer is processing. And the depth of the box, it takes longer for the sound to go deep and come back. So we need to keep the box size as small as we can to be able to get a good image of the Doppler. So I could probably bring it here to about that size there, and it'll be about, I don't know, 30% of the size that it currently is. So that bigger box means that the frame rate is slower. Now I'll just have a quick check here. Where is the best segment to place the Doppler sample? We want to try to avoid right up against the abdomen and right up against the placenta. So you want to try and get a trace in the middle of the placenta. And what effect has the umbilical cord coiling got to do with the Doppler flow? Not much, I don't think. It can coil heaps. All the cords I've looked at look coiled. The only time where you can't make a normal Doppler look abnormal. So if you have got an abnormal trace, the first thing I do is just roll mum around, and I'd like position on her side or something, and then I'd wait a minute or so and then take another trace, because sometimes if babies, if the weight of baby is squishing down on it, it can damp the flow because it's sort of compressing the cord. So by doing that positional change, you sort of release the pressure. So if it's normal, it's very difficult to make it look abnormal. But an abnormal trace, I would always take 2 or 3 of them in different positions to make sure that that was definitely an abnormal trace. So very quickly, and we have only got a couple more slides here. Biophysical profile used to be very popular because they didn't have as many machines with Doppler and spectral Doppler on it. And when that was a real rarity, they used the biophysical profile in lieu of. But now with CTGs and Doppler and better machinery, we can see things much more clearly. The biophysical profile has kind of fallen out of favour. And the other reason, maybe this is my cynical me talking, but a biophysical profile, a true biophysical profile, to call it abnormal, you need to have observed the parameters over a 30-minute period. So let me explain that. The biophysical profile is a non-invasive test to predict the presence or absence of fetal hypoxia. So it's data from the ultrasound imaging and fetal heart rate monitoring. There are 5 components, and you get a score out of 10. Now, for each component, it's either present or it's absent. There's no ifs, buts, or maybes. It's either you see it or you don't. Now, if you see it, it gets 2 points. And if you don't see it, it gets 0 points. So then you add up those 5 scores, and a score of 8 or 10 is normal. If you get 6, it's equivocal, and anything 4 or less is abnormal. The problem here is that to determine that it's abnormal, you need to observe that parameter for at least 30 minutes. I can remember when I was practicing clinically, to sit there and try and wait for a baby's hand to flex or for baby to breathe and just be sitting in one spot waiting for that event to happen for 30 minutes is just unfeasible. So when you have a normal active baby, it's very easy to say that it's normal very quickly, and it doesn't take long at all. But when they're abnormal, that examination starts to take a lot longer. So those 5 parameters that we're looking for, they do a CTG of the baby's heart, and we want to see 2 episodes of a change in heart rate by more than 15 beats per minute within a 30-minute period. So that's much, much easier to monitor when you've got the monitor on completely and you can just print out the trace. The next parameter, we want to see 1 or more episodes of fetal breathing, 2 or more gross body movements of the trunk and limbs, 1 episode of active flexion and extension, so either flex and extend the hands or the toes or the knees or hips. And then we also do 1 or more pockets of fluid that measure more than 2 centimeters. So as I said, for each of these 5 parameters, you either see it or you don't. There's no maybe about it. It's either there or it's not. If it's there, it's 2 points. If it's not, you get 0 points. You add those 5 scores up and you get a score out of 10. So it's fetal breathing, gross body movements, fetal tone, which is the flexion and extension, the reactive heart rate, and the AFI, so 2 or more pockets of more than 2 centimeters. So on this example here, we're watching, we can see Bub, you can see Bub panting and breathing there. So we're looking at the diaphragm, and you can see the movement of the diaphragm here indicating baby's breathing. And then you have to go and find each of the feet. You might be on one hand and it flexes and extends the other hand, and so you miss it. So it can be really frustrating when you can't see these things. And I think that in reality, it's more the time taken for this exam. There's not enough time for anyone to do this exam fully anymore, which is more the reason I think it's fallen out of favour. So we have covered 4 different ways that we can look at what the fetal well-being is doing and how well baby is. The first and most obvious is the cardiac activity. It's either there or it's not, and if it's not doing well. The amniotic fluid, and we measure that either the 3 methods. It's either subjective measurement or the deepest vertical pocket or the amniotic fluid index, which is the deepest vertical pocket in 4 quadrants added up. You can look at the umbilical artery, and there is a middle cerebral artery Doppler that you can do, but we haven't covered that today. And last but not least, we looked at the biophysical profile. So I'm now going to hand that back over to you and to see if there are any questions.
I don't have a question, but I want to say the presentation has been so good, and I have got some important tips on how to go about an obstetric ultrasound. I am connecting from Cameroon in a remote area. Most of the time, network does not permit me to connect with you. Thank you for the presentation.
Thank you so much. It looks like you've got better internet connection today than I have at my house, which is in metropolitan Melbourne. Thank you so much, Henry. I'm glad that there's something there that's useful for you. Is there anything you do different, Noki?
Pardon?
I was just asking Noki. There we are. Is there anything you do differently?
No. And I also want to thank you, Sue. It doesn't really matter how long you've been doing it. I learned so much today, and thank you so much.
Well, thank you so much. I'm glad it's not a waste of time.
No, not at all. Not at all. Thank you. Makes it easier when students ask questions to be able to give them clear answers as to why you want them to do things a certain way.
I think too, you know, if you're rushing and you're working clinically, you don't get as much time to figure out how to put those tips and tricks succinctly. And I think the advantage of what we're doing here is we're starting up newbies all the time. And so you have to get straight to the point, but you have to figure out the most efficient way to teach it.
Okay, thank you.
No worries. Were you going to ask something again, Henry?
Yes, I asked a question about estimating amniotic fluid index when you have multiple gestation, maybe like triplet. Do you measure across the membranes that are separating the amniotic cavities, or you measure each fetus in its own sac?
If you can see the sacs and you can find where the sac is, well, then you can kind of vaguely go, I want to keep to the right of this, to the left of this, and somewhere between. And then you'd measure the deepest vertical pocket. My total history with triplets in particular is one gestation, I think at the 18 to 20 week scan, and I followed up one lady into her 3rd trimester. We don't see a whole lot of triplets over here anymore. It used to be with IVF, but and the 2 ladies that I had scanned were naturally conceived as well. So we don't see it too often here. But again, I think this is where the more you've done, the more experience you have, and that's where that subjective assessment comes in. Because late in gestation, trying to find those membranes to delineate the different sacs can be really challenging. And so, first of all, you need to know from your first trimester scans, are there 3 sacs, or is there only 2 sacs, or is there only 1 sac, whatever. You need, particularly in monochorionic, monoamniotic, you need to understand if there is, and that should have been discovered, or hopefully has been discovered early in the pregnancy. But I think it can be very, very challenging, and there's not as much room, so everything's squished up. So I haven't done a whole heap of that tertiary level multiples to be able to guide you much further than that.
Okay, yeah, thank you.
Then, do you see triplets a lot?
Yes, we see triplets a lot. We see them a lot. Like once every 6 months, we see at least, once every 6 months, we see triplets. Cool. So actually this year, I follow up one. In the first trimester, I was able to see 3 different sacs. And in the 2nd trimester, I was still able to see, but in the 3rd trimester, it was difficult to differentiate where the extent of each sac, because the babies get, the uterus is tight and they are squeezed one corner, and it was very difficult.
Yeah.
Yeah, so where I work, the sonographer is like the key to tell the doctor whatsoever thing that he finds. And if the sonographer cannot provide the answer, then the doctor cannot also properly manage the patient.
Yeah.
Yeah, there's something that I see with some fetuses, but they turn out to be normal. The cardiac activities, like after 1 or 2 minutes, there is a missing beat. The heart just goes flat, then it continues beating. After 1 minute, then there's 1 missing beat. I was first of all worried, but over the years, I've seen that those fetuses are born and that they grow up to be normal.
I have done many a scan, particularly in 2nd trimester, where I've watched the heart rate stop and I kind of move on, come back to it, and it's fine again. And if you press on, if you're pushing quite firmly and you're just in the right spot, the pressure from the probe can actually, I've noticed, like if you get right on the apex of the heart, if you're pushing quite firmly, you can actually cause it to, and then you just take off your pressure and it starts beating again. So, I don't worry as much about it. It's just move away, come back. It might be because of the pressure. It could be an ectopic beat. Could be anything.
Do you think there could be a vagal response happening from the pressure?
I don't know. I mean, that's one plausible explanation, but I've had it happen a couple of times, and I used to like be heart in the mouth stuff because you're sitting there scanning and you're like, oh my God. And then you just kind of go in panic, let's just move somewhere else, keep doing something. Oh, and then you come back and it's going again. You're like, oh, thank goodness. So, and I'd seen it happen enough that it doesn't cause the same amount of freak out now. So, yeah, it possibly could be.
Okay, thank you. Next time, I will try to convince some of my colleagues to join.
Thank you. And if you have any ideas for a topic for next time, I've got a couple ideas, either some case studies, some like a guide to, how do you develop your skills, and how do you learn it, and what you can do to learn it faster, or I'm open to suggestions. So come back to me with some ideas.
Okay, I think I will do that. So our hospital run a small they run a small school where they train sonographers and the imaging technician. So I am one of the lecturers in the school. So from time to time, I think I'll get back to you to have some more resources.
No, sounds great. Thank you so much, Henry. And nice to see you, Alan. Nice to see you again, Eva.
Bye. Thanks, Suean.
Thank you so much, Suean. That was excellent.
Oh, cool. I hope there's something useful for you, Eva.
Yeah, finally understood these AFIs. I'm just looking at the numbers and thinking, I have no idea how they're calculated. So it's so good.
Yeah, there you go. Cool.
Yeah.
Demystified a little. All right then. Well, have a lovely evening and thanks for joining, especially all the way from Cameroon.
Yes, bye-bye.
Bye-bye.
Yeah.
See you later.
Bye-bye.